Welcome to this high-energy whiteboard explainer on diuretics. We are going to map out exactly how these crucial medications work. And we might even cure a confused neuron or two along the way. I'll be drawing this all out for you, highlighting the key pathways, and showing you exactly why we use what we use in clinical practice. So grab your virtual markers and let's get right into it. Here is our flight path today. Welcome to the nephron, the diuretic arsenal, thiazides, loop diuretics, potassium sparing, and finally, the treatment algorithm. I promise to pace myself so those English subtitles can actually keep up. Section 1. Welcome to the nephron. Let's talk pathophysiology first. So before we turn pharmacology into a giant bowl of alphabet soup, we have to ask a really basic question. Why do we even need to pee more? Diuretics increase urine volume, sure, but we don't just hand them out for fun. We use them to physically manipulate the body's entire fluid status. Think about it. When a patient is severely overloaded with fluid, maybe from heart failure, or they're dealing with high blood pressure, these drugs are our absolute go-to weapons. By decreasing that extracellular volume, literally grabbing sodium and water out of the blood and dumping it into the urine, we immediately drop the venous return to the heart. That decreases cardiac workload and oxygen demand. Basically, we're unflooding the whole system. Now, the anatomy of the nephron is fascinating. Imagine my marker tracing right over the proximal tubule, dipping way down into the loop of Henle, and cruising back up to the distal tubule and collecting duct. Location is literally everything here. These drugs mostly inhibit renal ion transporters, and their impact changes wildly depending on exactly which part of this tube they're blocking. Moving to Section 2, the diuretic arsenal. Let's look at our classes of weapons. I'm drawing out this chart for you because it's basically the ultimate clinical cheat sheet. The actual strength of your diuretic depends entirely on where it hits the nephron. Notice how the loop diuretics are the absolute strongest, thiazides sit in the moderate range, and the potassium-sparing guys are relatively weak on their own. We're going to see exactly why that is as we map out each class. Section 3, thiazides, the distal defenders. Let's draw a quick pop-up box right over the distal convoluted tubule. Drugs like hydrochlorothiazide and chlorthalidone, this is their turf. They block the sodium and chloride co-transporter, so sodium and chloride get trapped in the tubular fluid, and water just passively follows them straight out into the urine. What's super unique here is they can actually produce a really concentrated hyperosmolar urine, but, and I'm drawing a massive red flag on the board here, these drugs have to be excreted into the tubular lumen to actually work. If your patient's kidneys are failing, say their glomerular filtration rate drops below 30, these drugs are totally useless. You're going to need something way stronger. Now, every single med has side effects, right? No perfect solutions, just trade-offs. Thiazides absolutely love to mess with your electrolytes because all this extra sodium is rushing down the line. The kidney frantically trades it for potassium, giving you hypokalemia, low potassium. They also directly compete with uric acid for secretion, so uric acid backs up into the blood. If your patient has a history of gout, their big toe is going to turn bright red, swell up, and absolutely scream in pain. All right, Section 4, loop diuretics, the heavy hitters. These are the absolute strongest diuretics in our entire arsenal. Check out this mechanism. They block the sodium-potassium 2-chloride cotransporter right in the ascending limb of the loop of Henle. Why is that so ridiculously powerful? Because this one specific limb handles the reabsorption of a massive 25 to 30% of filtered sodium. The downstream sites literally cannot compensate for a load that heavy. So, if a patient rolls in with acute pulmonary edema, meaning fluid backing up into their lungs from heart failure, intravenous furosemide is your absolute lifesaver. This next point illustrates a massive difference you need to know for both exams and real-life clinical practice. Pay close attention to this one. Thiazides actually increase calcium reabsorption. They save calcium in the blood, keeping it out of the urine, which is actually fantastic for preventing calcium kidney stones. Loop diuretics do the exact opposite. They block calcium reabsorption, meaning they trash the calcium, sending it straight out into the urine. Here's a great little mnemonic for you. Loops lose calcium. Thiazides take it in. Simple as that. And speaking of side effects, loops can definitely cause hypokalemia, just like thiazides, but they have a very special, very dangerous side effect. Ototoxicity. We're talking reversible or even permanent hearing loss. If you mix high-dose loop diuretics with other ototoxic drugs, like aminoglycosides, you can pretty much say goodbye to your patient's hearing, or I will personally come smack your gluteus maximus. Section 5. Potassium-sparing and osmotics. So we just established that both thiazides and loops make you lose potassium. Well, when you're tired of losing all that potassium, spironolactone steps in to save the day. It works further down in the collecting tubule. By antagonizing aldosterone, it forces sodium out but holds tightly onto potassium. But be super careful here. The exact opposite of hypokalemia is hyperkalemia. If you give this to a patient who already has severe renal dysfunction, their potassium is going to spike, and that can trigger some incredibly deadly cardiac arrhythmias. Because spironolactone is a steroid derivative that blocks aldosterone, it also acts as a bit of an endocrine disruptor. It blocks androgen receptors and actually inhibits steroid synthesis. So in men, it can cause things like gynecomastia and impotence. But here is a truly fascinating clinical twist. Because of this exact anti-androgen effect, doctors will actually use it off-label to treat women with polycystic ovary syndrome, just to help offset those high androgen levels. Next up, a totally different beast, the osmotic diuretic, mannitol. This is not about blocking sodium channels. Mannitol is just a simple hydrophilic sugar that gets filtered right into the tube, but absolutely cannot be reabsorbed. Because of its sheer osmotic weight, it just drags water right along with it. It's a pure water diuretic, known as aquaresis. We give it IV, and it is a total lifesaver in the ER or ICU if a patient's brain is swelling. It reduces elevated intracranial pressure by literally pulling water right out of the brain tissue. Section 6, the treatment algorithm. Let's talk clinical strategy. You're going to literally write out your treatment plan on the chart just like this. For a patient with stable, routine hypertension, thiazides are your absolute bread and butter. Now, if your patient comes in with a flooded heart and pulmonary edema, you immediately drop the big guns, loop diuretics. And if you have a patient with resistant hypertension, meaning they're already on 3 drugs and their BP is still sky high, or a patient with heart failure where you desperately want to prevent the heart from remodeling and failing further, that's when you add spironolactone. I'm going to leave you with a final puzzle to test all this new knowledge. Think back to our whiteboard notes on secondary hyperaldosteronism. An alcoholic patient develops hepatic cirrhosis with severe ascites. That's all that fluid leaking into the belly. Which specific diuretic is the absolute drug of choice here? Pause the explainer, drop your answer in the comments, and let's see if you can crack this clinical case. Thanks for joining me on this whiteboard tour of the nephron, and keep learning.